And we have a quorum. You're going to do roll, I'm guessing you have roll call to act.
Yeah, I've noted who's here.
Thank you. Could I get an approval of the agenda, please?
Move to approve the agenda.
Second.
You. And is there any public participation online? I don't see anybody here. And can I get approval for March minutes, please?
Madam Chair, although I was not here for the meeting, I did read them over and I did not see. Approve them as-
Thank you. All right, we'll move on to old business, and the first thing is the compliance work plan.
Thank you, Madam Chair. That's not gonna help me much. All right, so I did make a few adjustments. I'm actually waiting for an approval of a risk assessment software that should be coming next week. That will help us with our work plan. So we just made a few adjustments on it. The things that are staying this year, we're going to be doing a 40B assessment this summer. So that's on there. We are doing a data security risk assessment that's going to be coming in August and September. So that's two high priority items that we have going on. And we are doing our ongoing annual coding audits. And that's something that we're working on. Let's scroll down through this on it. Some of the other things that we're working on is developing a vendor management tracking. This is something that we really don't have a good tracking on. We do keep track of our contracts, but then when we each annually or biannually sending out reviews of their updated security, or if we need to update our BAAs, we don't have a process in place to continually reassess our vendors. So this is one thing that we need to work on with our vendor tracking and our assessments. So this is one thing that we need to start working on this summer and really assess. So this is something that we determined that is going to be a priority to start working on this summer. And let's keep scrolling down, Sharon. Sanction checks and moving down. Training, environment. Rural health clinic, that is something added to the plan that is going to be addressed with starting our clinic, our Bartlett Family Medicine Clinic. Thank you, Sarah. So that is added to the plan of when that will be coming in July, August-ish. That is going to be a new regulatory and compliance plan that we'll need to sit in and move further down. And then that's on transparency. Okay. Things that we haven't looked at that we're going to be working on a risk assessment and adding to our compliance work plan is looking at goals that are coming off of the survey from Wildflower Court. And now that we have a new director of hospice, I'm going to be working with her to do a risk assessment with hospice and home care. And we're going to be adding those to our compliance plan also. So those are two things that we haven't added to our work plan for this year. Any other questions?
So Madam Chair. So when you say like the start date is 6:30 for the vendor.
Mhm.
So that's your start date. That's when you anticipate you're gonna start.
Mhm.
And then, you know, one of them myself, the end date was August. Or,
The reason why I put that on that is I'm anticipating an upgrade to one of our current softwares that we have actually has a vendor tracking process within it. So with that upgrade is being able to put all of our vendor, especially our software vendors in it to be able to put everything in it. And I'm actually using in our work plan, it used to be in an Excel spreadsheet. I'm now using a Microsoft list process that I started putting it in a new product that we have to try to track dates in it and actually task out to people. So this work plan is a little bit in development to try to make it using a different software product.
so one of the things that I do really like about this is you say what the priority is.
Mhm.
And I love them.
Yes.
That really helps
Yeah.
me just looking at a snapshot. So
Yeah. So, and I'm hoping once we get our risk assessments done, that it'll be a little bit clearer, then each month it can be a little bit more dynamic. And I'm hoping once it's built, we'll be able to look at the software and be able to show it.
And so this report comes out of that software.
Yeah. Mhm.
You got my feedback.
Yeah, yeah, it's putting it into a PDF is not the best way to do it. I'm hoping it's harder to give it to you in a board packet. I'm hoping that it'll be able to be showed dynamically in the meeting.
Same for my over 40 eyes. This is hard to read.
well, it did.
It is.
It did. I was like, my computer just blowing it up, trying
Yeah.
to figure out what it was. But
Trying to make it into a PDF is very difficult.
once I did understand it, that was great. So
Yeah,
It's nice that you'll have it all in one place and be able to pull stuff from it.
and then I can task out to people that can update it in real time.
Any other?
I have a comment question. I'm just curious, Gail, is it, you know, family practice didn't have a compliance officer. And I imagine that home and health hospice may not have had a dedicated one. Now, of course, the nursing home is big enough to have had one, but have the requirements bumped up because the hospital now owns the rural health clinic? Does that mean that there's more regulation? Oh, so it's
No.
always there.
A practice always had to have a
Policy
compliant.
procedures, okay.
So any family, like your practice,
Right.
you're the compliance officer.
And the,
Yes.
yeah. Safety officer.
Yes.
I remember going to a meeting there and they said, and they wanted to talk to our computer, specialist for the practice.
That would be you.
I have 1.5 employees.
Yes.
So so there's not a bump in regulation, but there's a conservation of resources because you're a specialist in this, so it's easier for you to do it for wildflower
Yes.
and then home and health hospice. I'll
Yes.
be appreciating that.
Yeah.
Very good, thank you.
Before on your plate for it.
Yeah, that's why we are doing like education on, like this month, we chose to do it on long-term care because there's a lot that, Deb has to know, but you also have to know for the board. And the same thing with hospice, there's a whole set of regulations for hospice and oversight that the board has to be responsible. And with the rural health clinic coming on board, there's a whole nother set of regulations that, you have oversight.
Everybody's job got bigger
Yes,
and it's a good thing.
yes.
Okay, any other questions? Alrighty, moving on to the dashboards, Robert, quality. Main dashboard.
Hello, Robert here from Quality. Hopefully you can hear me okay. So I'm going to present the 2025 Board Quality Dashboard, and this is the same dashboard you guys have been looking at. There's a couple differences. I'll highlight that. And what we have is in our current conditions, we have first quarter 2025 data populated now. So under exceptional clinical care, of course, we want to maintain our accreditation readiness. We haven't had a catheter-related bloodstream infection since 2008. Our readmission rate is 7.9%. Our goal is the national average, about 15%. So that is good. Now, as far as our hospital, it says achieve, but it should be achieve and maintain hospital compare overall quality rating of 5 stars. The April update by CMS, which we would have been 5 stars at that time, we currently are still, if you were to go on it right now, we're going to show 4 stars. That update has been pushed out to July. So fingers crossed in July, we'll get our 5-star rating and we'll be able to maintain that. Under the value tab, we have sepsis. Last 2 quarters, we've been 52%, which is just shy of our goal. So hopefully we can meet our goal, which is compliance to the CMS SEP1 measure, hopefully in the next little while. We have our falls with and without injury rate per 1,000 bed days. You see that there. Restraints and seclusion, these rates are per 1,000 patient hours. Our surgical site infection is for 2025 first quarter 0.20. Last year it was 0.17. We have our catheter associated urinary events. We didn't have any. No C. diff. Hand hygiene rate for quarter 1 is at 93%, which is above goal. Now for the safety culture index and the prevention and reporting on those, we're going to have to wait until the survey cycle repeats. So that has not changed. For our HCAHPS, which is our patient experience that's under the auspices of CMS. So we look at overall rating and then we look at likelihood to recommend. Overall rating for first quarter was 80%, a little bit shy of our 85% goal. And then we had 83% for likelihood to recommend, which is above the goal. Under extraordinary engagement, we look at OP18B, which is the median actually time patients spend in the emergency room before leaving from the visit. We are currently in first quarter 150. Our goal is 125. Just for reference, national average is 162 minutes. The resources, teamwork, pride, reputation, employee engagement, that again has to wait until our next survey that comes out. Physician engagement, same thing. We are currently still working on developing that robust patient family engagement program. Under access and efficiency, we have an OR utilization metric there. And we have the start time percentage. That data has yet to be updated. And then the last thing is Jeanette's team has changed their metric. We were looking at some SDOH screening rates, but this has been changed to what is called the carry forward rate. And will attempt to explain what that is. Carry forward rate is when a nurse queries a provider for some update in the medical record for a billing or compliance reason, and the provider agrees. Carry forward is when it actually gets updated in the EHR. So that is happening at about, currently 84%. The goal for that is 100%. And that's all I had. Does anybody have any questions?
Questions on the OR utilization and start times? I know there's been challenges in the past of everybody being on the same page as to what those are. And I'm kind of wondering where we're at with that and if we're going to be seeing those numbers.
Yeah, we didn't have that data fed to us. Well, the OR utilization is current for quarter 1. The percentage on start time, we're still working to try to get accurate metrics in that area. I don't know if Gail had anything to add there.
Yeah, through the chair. So we did at the last Cervical Services Committee meets every other month. And so the last meeting, which was, I'll go there, scheduled to meet next month. Everybody decided, all the surgeons decided what on-time start was, and it would be wheels in. So once we can have our dashboard kind of reflect that, we'll have some more data, because right now it's pretty, it's kind of scattered. But they've all agreed to wheels in is the start time, so.
Nice work getting that done.
So that's a goal that we're reaching for and working within the dashboard, that the surgery dashboard, to making sure that the information that is being fed in to that is accurate.
Questions? Okay. Lab dashboard.
Okay, so the main one on the lab dashboard is our blood culture contamination by department. So as you can see, this is a monthly totals and trending nicely, because blood cultures, if we have contaminations, of course, we're not able to treat effectively with antibiotics, and the blood culture is not effective. So lab has been doing a lot of work with nursing to making sure that we're collecting appropriately. And for 2 months in a row, we are meeting our goals. So this is great. So that's all I can say on that. So hopefully May will be the same. Just fingers crossed.
Just kind of give me an example of what the contamination could be.
So a lot of times what happens is when you're collecting, you're getting contamination from the skin. So if you're starting an IV and you're not doing, good process, that's what's happening a lot is I will say nurses are not as effective in doing, we're too fast and we're not minding our technique as much as lab does. So nurses are culprits of getting contaminations into the culture jars. Lab does a better job of it than we do.
Sure. Can I add to that? I think sometimes that what we're seeing too in the ER is that they'll draw blood cultures from an existing line, or the patient comes in from EMS, who's a really hard stick. And so they've tried and they can't, so then they pull that, and then maybe EMS hasn't prepped the line, because then EMS is kind of a little, it's a load and go or something like that. And so we're trying to train to that too, but kind of is it better to have the blood culture than not have it if they're a really hard stick? So we're seeing some of that dynamic playing into this as well.
Anything else? Medication dashboard.
Medication dashboard. So what we're seeing here is still the issues. A lot of it has to do with in surgical services. We're still seeing issues, and a lot of this is related to our anesthesia technology that we're using. So this hopefully some of those problems will go away with the when they change over to their new technology that they're using. Right now, the anesthesiologists are having to document in multiple areas, and then what the charges are not being charged correctly to the right patients. And a lot of our work is having to go, pharmacy has to go back and make sure that when something's pulled out of Omnicell, it's being tracked correctly back to the patient and documented correctly, because we have 2 documentation systems that don't talk to each other. So all of those are being tracked related to the cases in the emergency, or excuse me, the OR. So that's where you're seeing the documentation errors, and it's being tracked back to what is being pulled out of Omnicell versus what was in Meditech versus what is in the anesthesiologist's records that they're having to correct. So that's where you're seeing a lot of those trends there. In the other units, you're noticing that there's a lot of decreases in medication errors where the green arrows are going down, which is actually good. You're seeing your scan rates are going up, which is excellent. And then you're seeing your reporting of your good catches is going up, which is what we want to see is people are reporting things before they reach the patients.
I have a question. Is your question about the arrows or no?
Yeah.
My question is when I compare the two columns, define for me what the trend means in this. Because on some of them, the arrows are going up, but the difference between, is it the average? The estimate, if I multiply Q1 by 4 quarters, we're expecting it to go up. Explain to me what the trend is.
So what my trend was from the quarter 4 and then quarter 1. So you're not seeing that. So that was my trend that you're not seeing.
That's helpful.
So yeah. So I looked at that and then I'm pulling that trend from the last quarter to this first quarter. So.
Thank you. That makes sense.
Mhm.
And then from my non-surgical friends, correct me if I'm wrong, the patients are getting the antibiotics. It's just that the anesthesiologists have always handwritten for years, and there's a mismatch between the Omnicell shows it's not there, pharmacy
Yes.
knows it's not there, but it's not in the correct medical record, so it
Right.
shows up as an error. But really, the patients are getting.
Yes, correct.
That's much large.
Yeah. And it's not just, it's any of the medications. So they document in a different record than Meditech and then how it's pulled out. So, and it could be also waste too. So if you're pulling out a medication and you're giving 50 of it and you're wasting 50, that's also shown in here is there's a missing of where did the waste go because it's not showing back into it. So it's not just the meds getting to the patient. That's those documentation errors because of the way it's tracked back on the process.
Are they looking at changing how the anesthesiologists document or?
Yeah, and
Yeah, that was here. We have a new system that went through ISAC and looked at all of that to be able to implement. So the current system will now actually be able to have information going from that into Meditech.
That'll make it more accurate.
yes, and that's why we were tracking these so closely because we can justify the cost in changing up a new system for them because there's a lot of other reasons also, but this is one of the justifications because pharmacy then had to go back and ensure that the correct charges were captured for the correct patient because it could probably talk about how many mischarges there would have been if we weren't being so diligent capturing each month.
It's about $15,000 to $16,000 a month if we don't go and reconcile.
I think Lisa has a question. Lisa has a question.
Oh, I'm sorry, Lisa.
So I just want to be clear that I'm clear. In 2024, that includes all 4 quarters.
Correct.
Okay, so my question is about Wildflower Court. So quarter 1, there were 16 errors. What kind of errors are they having? You guys having at Wildflower Court?
A lot of, I can speak to it or if you want to, Deb.
Is it accurate to say a lot of those were actually, they didn't reach the patient, it was pharmacy errors?
Yes.
And we're working with the pharmacy on that, so it's more, maybe the wrong, it's in the paperwork piece, wrong medication was sent, or even in the transcription.
Yes.
Medication. They are, an electronic system and, have noted that kind of our system is a bit antiquated the way we fax things over to them. So there is work on their end to be done with that.
Yeah.
Yeah. So not that it's reached the patient. There may have been a few.
Yeah. It's mostly with the contract pharmacy sending the wrong medication, so the patient dosage changed and the contract pharmacy sent the wrong medication, and then you would have to, they're doing a lot of tracking of those back.
Where are you guys using?
Genoa.
Okay, where are they at, Seattle?
It's a small, yes, and it's a small satellite pharmacy here in town, but they are based out.
Okay, thank you.
Yes.
So if it's not actually reaching the patient, yeah, would this be considered more of a good catch on medication?
It probably should, yes, we should probably should capture them as that. Yeah. Point, yeah.
I think through the chair, I think they can be captured in both places, because really, if you, on the nursing side, if you pull out a med or you have a med there, but it doesn't reach the patient, it's a near miss.
Yeah.
So it could live in both spots.
But
Absolutely.
if it doesn't reach the patient, then
Yeah, even if like, if I go through the chair, pardon me, if I go through like to the Omnicell, or I go and I pull a med out and it's not the right medication for the patient, it's still considered a near miss, even though it never reached the patient, because it nearly reached the patient.
but right now. So right now, if you go into Omnicell and you pick and a wrong med gets dispensed, then that's going against Wildflower Court as having medication error, is that correct?
Well, that was just an example through the chair. It's the same kind of, it's the same kind of process of as far as a near miss. So there's different areas. They're like near miss, didn't reach the patient, near missed, was caught, caught right before the patient, or, got to the patient, no harm. So both of those can be, so if you, anytime you have a medication that is there, and like say, maybe it's not caught and the nurse goes to pull it, and then is walking down the hall and goes, oh, this isn't great. That's considered a near miss, even though it didn't never reach the patient.
Questions? Okay, workplace safety dashboard.
So workplace safety, this is one we've been now tracking for a full year. So we have a full year of data. You'll see we don't have a goal determined yet. But this is something that we are talking about now, as being able to establish a goal. There are no national benchmarks for workplace safety goals, but now we can establish something as a organization. So as you can tell, there is a little bit of an uptick, and this is also an uptick in areas that are actually increased reporting too, because now staff is aware of the importance of reporting. So you can tell emergency services has increased their reporting. And the other thing, we have had an uptick of JPD call to campus. Those are two of the areas that we have an increase.
Where are they being called? What's happening?
Some of our, we've had some difficult patients, and not really just either difficult patients or discharged refusals to leave.
Through the chair, we're also encouraging the staff to call more for assaultive behavior, and get that attention brought to them. And then if the employee decides that they don't want to file a report, then they can tell JPD to go, but we're really trying to encourage people to call to get them.
Yeah, serious stuff.
So the line JPD call to campus is under physical plant environmental safety reported. And so how is JPD called for physical plant environmental safety issues? Maybe beyond the verbal and physical incidents listed above.
When we designed the dashboard, that was seemed like an appropriate place to put it for environmental safety, because most of the time it is our security team that was calling JPD for an environment. The first couple of calls we were getting is for a either a violent visitor or patient. So that's why we chose to put it in that area.
So the categorization, the measurement or location is based on who calls, who makes the call or reports the incident? Or
The other ones on top are based on the area of call. This one was just a bucket for any time JPD was called to campus. We haven't been determining what location they're at right now.
And do you feel staff are feeling better about the process?
I think it's complicated. I think we, a few years back, the laws were passed that made assaulting a healthcare worker a felony. You have to have somebody willing to press charges or not press charges, willing to file a report and then say, yes, if they bring them up on charges, I'm willing to testify. That's complicated and difficult in a small town where, the employee can give the hospital address for their location, but has to give their full name on the report. And so employees are hesitant to do that in a small town because it doesn't take much to find people. So we're really trying to support them in that and try to find other ways around providing that support. One of those ways is, to at least call JPD to see if, to give them that opportunity. But that's kind of what we're hearing. And I don't know if Chad wants to chime in, but that's what we've been hearing. Okay. Is that concern about putting their name out there?
I have a comment.
Because I'm head of the quality for the hospital for medical staff, and Jody Totten now is the chief of the ER, and so she has sort of made, I don't know, Kim, it seems like she's making it more of a priority to report. So I think that's part of her push in the ER to take nurses. So some of this is going to be increased reporting, but it's a good thing.
Yeah, definitely. Any other comments, questions? All right. Moving on to new business. Education session.
Well, okay, so I did include for your reading pleasure and enjoyment. Hopefully you got a chance to read this. This came out in November 2024. So Sharon, you can just scroll through this whole document. It was actually easy to read. So if you can go to the PowerPoint, Sharon.
Oh, it's gotten a little better.
They did. They only had a few political comments in there that made me go. You could tell what was written pre-election and post-election. But this document was last updated before this one in 2008. So it was a long time coming. So this is actually, it was a good time for me to start working on this because I started working on this and lo and behold, I put it out in the universe to bring the surveyors into Wildflower Courts when Deb was on trip. So Kim did an excellent job in her stead of bringing our survey to fruition. So in November of 2024, the OIG released the nursing facility industry segment specific compliance program guidance, the GCPG. So this is their updated guidance. The last one was in 2008. So we are going to live with this one for a very long time. And what they did interesting with this one is they really combined both compliance compliance and quality in these documents. So the OIG is really taking a stance that compliance and quality are really one and the same in a lot of ways. So it's actually very interesting that the board put compliance and quality together. It was like they were thinking the same way as CMS. So anywhere that any organization that gets money from CMS needs to have requirements of participation. So we used to call them conditions of participation, COPs, and now they're changing it to requirements of participation. So you will see ROPs now. So if you want to go to the next slide, Sharon. So the OIG quality factors. So the reason they're doing this is if you look back at nursing home facilities, you can see back in the history of nursing homes and, the horror stories of tying people down to chairs and having really bad nursing home outcomes, bad nursing home experiences. And then during COVID, nursing homes during COVID had some really horrific outcomes. So that's why the OIG really took a hard look at nursing homes afterwards, came back to this. So they really looked at this of what is important for nursing homes to have quality. So staffing levels, looking at their infection control, emergency preparedness, because that was really important during COVID, background checks, looking at adverse events and looking at appropriate uses of medication. So those are some of the big key issues that this document really looked at, and we're going to just kind of briefly go through before Deb talks about it. So Wildflower Court is part of Medicare and Medicaid programs. They get most of their funding through Medicaid and some Medicare. So that is why we need to be very cautious on what we do. And besides our mission as an organization to provide the best care for our patients over there, we want to make sure that we are meeting all the standards. The survey that we just had over there, I just sat in their quality program, their quality program. We spent an hour and 10 minutes talking about our quality program report with the surveyors. So they are very concerned about what we're doing for quality improvement and assurance. So the state is very interested in that, and it's very important to them. So that is something that we need to focus on. So next slide.
Can I ask a question? Sure. So you said that they're very concerned about it. Are they concerned from a global perspective or specifically that we need to improve?
Global. They wanted to know all about the quality plan that we have in place and how that goes right down from the board level to the chief officer that you have, all the way down through it. So they wanted to know the whole, how you, as the board, how you heard about everything that happens at the Wildflower Port, how you were informed of any events that happened, what your role was, what the Dr. Malter brought to the table at quality meetings. They asked, what does he bring to the quality meetings? I mean, that was their question. So they were, wanting to really drill into the quality plan. What processes were in place to ensure falls, pressure ulcers, medication errors. They really drilled into everything. And that was a really strong focus of their survey. And then they went out and they looked and to see that that was in place.
I assume we did well. We have experienced people.
You will hear about it. Anticipation. So you'd have to wait. You'd have to speak to the end of the meeting. So another thing that really with compliance is false claims. So quality and safety concerns, lead to false claims. So every time we are sending in a claim, we are testifying that we are providing the care for the patients. When Tammy sends in claims, she is testifying that we are providing a level of care and for the patients. So if we are not providing that level of care for our patients, we are submitting false claims. So it's really important that we have appropriate housing, appropriate staffing. We're providing them with their activities and if they need any psychiatric care. So. So staffing levels, this is why when Deb comes to the board and she talks about appropriate staffing levels, she's talking about how her staffing is. She's talking about what her facility-wide assessment is every year. She's going to be bringing that back in a couple months and talking to you about what her needs are at the facility to care for the residents. That's looking at it every single year of the type of the scope of patients she has and what she feels that her staffing levels are going to need, that she's going to have, and what her recruitment and retention are for her staff on it and her management of it. And then looking at what type of competencies that she might need. Is she's going to need a higher level of staffing because she's looking at taking more complex patients on. You know, this is something that she's going to be looking at every single year. A facility-wide assessment is required every single year for her facility over there. Care plans and resident activities. So this is another area that's really important that we have to do for our residents, and we have to look at it every year. We have to meet the needs of our residents. So if they change based on our facility plan, we can't keep doing the same activities because depending on the type of patient, type of residents we have over there, we have to cater to their needs and address their mental needs because depending on the type of patient, type of residents we have there, their activities need to meet their interests and meet their support of their mental needs and their abilities. So that's something that we have to decide every single year. Are we meeting their needs and looking at that? And that's an ever-changing need every single year. Yes.
One quick question.
Mhm.
To the chair. So don't you have case managers over there that manage each individual's person's case?
Yeah.
So if someone is being discharged from Bartlett over to Wildflower Court, they work Bartlett's case manager and
Yeah.
Wildflower Court's case manager to make sure that they're on a great discharge plan and
Yeah.
plan where to get them, correct?
Yeah, and that's something that's really important. So before Deb and her team take a patient on, they have to consider what their needs are and if they're going to be a long-term patient resident there, she has to determine will that be able to be cared for. So if you have a patient who is really complex, so say if they have psychiatric needs or they have, complex medical needs, she has to look at it not just for, 6 months or a year, it could be 5 years. Are we able as a facility to meet the needs of this resident for a long period of time? And does it meet with the needs of all the other residents too? So, everyone says, oh, we have to get this patient out of the hospital and over to Wildflower Court. And it may not be the fit with the community at Wildflower Court. And that's something that is kind of a tough part between the hospital's case management and Wildflower Courts. Because yes, we want to get them out of the hospital to free up our rooms, but then they could be a Wildflower Court for a very long time because we can't just discharge them for Wildflower.
So in this particular slide here, you're talking about care plans. It's more of like the global facilities care plan than the individuals.
Well, you have to meet the needs of the individual, and Deb, feel free to jump in anytime. You have a nurse who's working on their individual care plan, and it's very customized to the person and their needs. But you also have to look at the big picture of what you're doing for the organization and Wildflower Court.
Yep.
No, I just 100% what Gail just said, right? So this is definitely talking to each person that we have in the facility, right? Specific care plans, specific activities. One of our test questions, you have to have an activity available that's going to be interesting, and it's very specifically tailored to the individual. But all the individuals together, have like they are a global piece in that facility. So we have to make sure that residents, we're going to be able to meet their needs, social, physical, medical. And so although it is very individual, global at the same time, looking at the big picture as well as the individual. So, yeah.
And that's what the survey, I'm sorry, just one more question. And that's what the surveyors were really concerned with. Is we're all playing, correct?
Yeah.
It was updated as the years go by.
Yeah, because isolation is something that is real for when you have people in a facility too, because you want to have that community connection too.
This is just satisfying my own curiosity. What is the stay for the person who's been there the longest? How long have they've been there?
I'm sorry, what was the question?
On the state resident.
I can't speak to currently. I will tell you that in my years working there, I had a resident for over 20 years. Over 20, like historically, like in the past. I can't speak to this right now, but yeah, I mean, long-term stays. It's not, I don't ever like to see, although technically we are a nursing home, I always like to see it as a long-term care facility, right? It's not just for the grandmas and the grandfathers, for other folks that have, other people in the community that have needs that.
I know someone, I know people that were there when I worked there, and that was 20 years ago, so.
There's probably some that have been there since I worked there. That's been.
Yeah.
Like this is their home.
Yeah. Okay, anything else? Maybe. So care plan meetings. So this is what we talked about. So before admitting a potential resident, so you have to identify the current and foreseeable services, making sure that we're able to maintain the services for the resident for their entire stay. That's really, critical. They do weekly care meetings, and they talk about the residents' needs and, any concerns that may be coming up and looking at what they're needing.
And every resident, their care plan is addressed every quarter, so every 3 months, fully addressed. Make sure we're meeting.
Activities. So if you have never been over to the activity room, I love this. I love their activity room. They have the best music over there. So you should go over there. I think they have a great activity program. So I think this is one of the keys for any facility when you look at it, is making sure that you have an activity program that is varied. Looking at it, that it has a rotating schedule. You need to make sure you're looking at the cognitive, physical activities that are reaching out to different people in different times, making sure that the residents' families are welcome, bringing in, the one thing I've always loved about Wildflower Court is it brings in different generations too. You'll go over there and you'll see children coming in and different groups coming in. So that's the one thing, is making sure that we have a really dedicated activities program. So that's really important for having a robust activities program involved.
And on that note, Wildflower Court was once a certified eating facility in philosophy, and it focuses on eliminating loneliness, helplessness, and boredom, because those three things have been proven to absolutely just decimate a person, right? Their life physically, mentally. And so that's really a goal of ours, right? You know, to have this robust activity program and have things available for people and different, like Gail said, generations coming in, whether it's music, kiddos, animals. We haven't, you know, we kind of said, I don't know how robust it's been in the last few years, you know, but I'd love to get back there again, even having animals in the facility. So it's a good philosophy to work
What's
with.
that acronym again? What you call it?
Right?
Yeah. Eliminating loneliness.
Helplessness and boredom. Those are the goals.
Medication management, key things on medication management, Carly's over there, she reviews medications monthly. Really, the big thing is making sure that we don't have medications that are unnecessary for, the residents. So any unnecessary drugs, and then psychotropic drugs. So we're not giving any medication for a resident that is not necessary to treat any diagnosed condition. So you're not trying to sedate anyone for behavior. So, and then if they are giving a drug, you're trying to reduce that to the least amount of drug that you can. So that is one thing with our pharmacist now who's over there is really amazing with looking at it at all of the residents' medications on a monthly basis. And she's involved in the coffee program and all of the care plans and really very proactive right now. So I think that's a really good fit of having a Bartlett pharmacist doing all those medication reviews. So. Safety, this is one thing that they're really looking at right now. Of course, we look at, Charlie has been really engaged with looking at our infection rates and making sure our residents are getting their vaccines to keep away influenza and any other COVID over there, but then also looking at how to identify resident abuse, neglect, also looking at injuries, resident to resident abuse. So these are really important things that we look at and making sure we have the policies in place, training, and continually monitoring this for our safety in our organization. Jim Bell is our assistant Don right now, who does the training programs over there and monitoring that. And then facility initiated discharges. This is something that is actually really a complicated area. There's actually a few reasons why someone can be discharged out of a facility. The first reason is if the resident's welfare or needs cannot be met at the facility. Or is it if the discharge is appropriate because the resident's health hasn't improved sufficiently, so we fixed them, they got better. The safety of the individuals at the facility is endangered because the clinical or behavioral status of the resident, so that they're making the other residents at the risk. The health or the individuals in the facility were otherwise endangered, or the resident has failed after reasonable or appropriate notice to pay or have paid under Medicare or Medicaid a stay at the facility. So this is a very complicated thing to manage or release someone. So any residents that are meeting these criteria, we must give them notice. we must talk to the state ombudsman and giving them 30 days in advance of discharge. This is actually very rare to do, but it is something that is available with our facility. Any questions on that? So Medicare and Medicaid billing, some of the big keys on that is making sure we have our resident assessments, our care planning is in place. We have tracking of our progress and outcomes. And we have proper documentation of our services that are provided, including like therapy services like PT, and other wound care services. Making sure our coding is correct. The 3-day rule, so if we're bringing someone in, if they have a stay at the hospital prior to, they have to meet that. And then, of course, we're now having value-based payment models and programs for NEPs coming forward,
So,
just like our hospital has.
so a couple of things. I don't want to know a little bit more about the 3-day rule.
Okay.
And then the SNF Medicare, Medicaid billing. So I know that in some rehab facilities, there's an algorithm that you would put into the computer that would say, okay, this is what our patient's diagnosis is. And you put that in there when the patient came in. And the algorithm for Medicare, Medicaid would punch out when the patient has to be discharged and Medicare, Medicaid to stop paying. Is that anything to do with a SNF, or would that be more of a on the rehab side? Follow what I'm saying?
So, I mean, I think because it is a long-term care facility, it's more just about like, you have to have a qualifying diagnosis, right? Which is why people can get too well to stay there. And then, of course, we need like the source of payment or whatever, but in order to qualify, we do punch things in like diagnosis codes into the platform, but it's more just, do they qualify to stay there, right? It doesn't give us any length of time, right? Because it's, for Medicare, the expectation is that they're coming in for 100 days, right? So if they've gone to the hospital, they've had at least a minimum of 3 days at the hospital, that qualifies them for the Medicare stay in a nursing, the 100 days in a nursing home or long-term care facility, so skilled nursing. So yeah, once they hit the 3 days and they're able to be discharged from the hospital, they have a qualifying diagnosis, then they come in and under Medicare for 100 days, and the expectation is they have their rehabilitation. And I believe after they go home, I think it's a 60-day period after that before they can have another 3-day qualifying stay.
It is on the rehab arm, but.
Yes.
Yes.
So this is your role in compliance and quality oversight. So these are the recommendations by CMS that you should be looking at and asking for data and information on. So the things that we should be bringing to you are any complaints, grievances that are coming, satisfaction surveys for residents and family and staff. So our staff get bundled up in our Press Ganey satisfaction surveys we do every year. And then any resident or family surveys we would be bringing to you. Looking at our turnover rate and any interesting data that come from exit interview reports should be coming to you. Any state, federal surveys. Looking at our resident outcomes, care delivery reports, event reporting, our nursing hour reports, our quality indicators, financial reports you get in the finance committee. If there's anything from any internal audits or concerns from that we're doing, and then our POPI program progress.
So back to the satisfaction surveys, and you said the staff is in the Prescaney. Do we capture the department that they're in?
Mhm.
So we can isolate the data for each of those departments, including Wildfire Corps?
Yes.
And I guess that's my thing for Chad. So do you do exit interviews with employees that are leaving?
We have two options for exit interviews. We have a online process where someone can actually go out and fill out the survey, and that's sent to all staff. And then recently I've asked Maria Les, who's come to our team, to start doing them in person. I feel like there's a lot more value to sitting in person, and Maria has such great relationships throughout the organization that having folks sit down with her or having that option has been very enlightening. So we're just rolling it out. We're going to need to put all that information into, it's easier to take obviously the online piece and build a report out of it versus having the more quantitative or qualitative approach of the in-person. So we're working on that.
How will that be delivered to the board?
At this point, it'll be a presentation. It's a simple deck.
How often will that come to this deal?
That I would probably say would be put into Deb's annual report for Wildflower Court. I would say would be probably a good summary, Tom.
The same would go for the organization as a whole.
I think that would be
How often an annual report? Except, I'm assuming that if there's something that really
Yeah,
pops out that you.
yeah. I would think if there would be a significant trend, we would bring it sooner. But other than that, I think Deb would have a putting it into her annual or her semi-annual report from Wildflower Court.
Yes.
But could I ask the question, can you remind me when those reports are due for the board? Are those at the end of the calendar year or when?
Deb and I are working on what her cadence should be for Wildflower Court, since she's new to the role. And that hasn't been really, since we've taken over Wildflower Court, we haven't really established what the cadence should be.
Thank you.
Definitely want to get that information too.
All right, any other questions on this vacation session?
Sometimes you get external audits like CMS or.
More frequently than you think. We get not so, I should say, don't pull that out in the air, Shelley. We actually get enough audits that come through to Rachel and to on different auditing.
So kind of like the,
Like maps and things like that, and the racks and things like that, yeah.
okay. It's just
Yeah,
typical.
yeah. This month, we're doing a internal audit of infusion next week, and then our next internal audit is actually Wildflower Court that we're gonna be doing on surprise. So we'll be doing it in next.
All right, any other questions for Gail? Now we're waiting for the Wildflower Court survey results.
Yeah,
Yep, that's next.
Okay.
and there's not a slide for it, so.
No, and actually, gosh, this is gonna be such a, because as far as the results go, we don't actually have them yet. I'm expecting an email tomorrow, and there's a platform that I'm gonna go online and log into, and that will give us the full report. There were some areas, of course, and I will just say, first and foremost, you know, here I'm reporting, I wasn't even in-house. Kim did an amazing job, and now she's like stepped out. So I really appreciate her taking over while I was not there, which is unfortunate. I know the staff performed really well. Survey experience was actually really great. Sometimes it's a 50-50. It was a really wonderful experience. There were areas of interest that the surveyors did notice. My understanding is those were not too high level, not too widespread. I can't even speak to the things that they mentioned just because they take what they give us an exit interview, so maybe we have a very general idea, but then the group that's there takes it back to Anchorage and for the next 10 days, discuss with the group in Anchorage and go back and forth, and then we'll send us the final, and that's what I'm expecting tomorrow. And so it's unfortunate I can't really share any more right now because I actually just don't have it to share, but I will after we get it back. So they have 10 days to get this information back to us. And then once we receive it, we have 10, they have 10 working days to get it back to us. After we receive it back, the report, we have 10 calendar days to turn in our plan of correction on how we're going to correct everything. I do know that as they were in-house and talking about things, bringing things up, we were able to step in and do some corrections even while they were still in-house. So that's always a great plan. Hospital does it with the Joint Commissioner here. So they were able to do a little bit of that while the surveys were in-house. We'll still see it on the paper though. But again, I can't speak to that because they'll be making those final determinations. But again, tomorrow is the deadline for us to see that format. And once we do, we'll be able to share more with the viewers.
Board meeting.
It's
And the good news is that you didn't have any pep tags or any really bad things, because you would definitely know about this.
right. So, yeah, no, I was really,
Have a good job.
that's
So good job.
No, the crew is amazing. They did a really great job. And it's really good to have them come in, right? Because they're just, they're looking at all the areas and just showing us areas that we can really improve on. We welcome that, right? We want to provide excellent care, right? We want to be an amazing facility to be at. That's our goal. So more to come.
Okay.
On that. I did check. I was hoping sometimes, I was expecting maybe today potentially even, so I could maybe share something, but it did not arrive yet.
Great, thank you. Okay, first quarter complaints. Reports.
All right. So I'm starting this out with a summary of 2024 of what we had. So in 2024, we had 11 HIPAA reports forwarded over to our HIPAA privacy officer for investigation and closure. We had 23 human resource concerns that we forwarded over for investigation and closure to human resources. And then we had 8, we have employee fair treatment concerns, which were basically when they felt they were not treated fairly or equitably by either a provider or another staff member, those type of concerns that were investigated by HR. 14 mid-staff rules and reg deficiencies that were reported and closed. And then 27 appropriate care concerns reported. So those, when we talk about appropriate care, those are concerns of was the care that was given, did it meet standards of care? So looking at those, we always do a root cause and looking at it, did it meet standards of care and closure and move through? So that was the total of 2024. And then, Sharon, you're gonna have to make it a little bit bigger. Oh, thank you, thanks. So then in quarter of 2025, I pulled this report out of our reporting system just to kind of break it down a little bit more by department, and you might need to go a little smaller so I can see the full document. I'm breaking it down a little bit more by area just to give us a little bit more of a breakdown so I can do it quarterly. So I'm using those same areas, and then I also added hospital access issues because this has been kind of a concern that it keeps coming up of, do we have safety concerns with people using their badges or getting to different parts of the hospital inappropriately, especially secure areas. So that is one thing that I'm starting to track also. So in administration, we've had two, and that's a kind of a large area. It's not just this building, but it's a little bit larger that covers administration, the second floor, and then also the building next to us. We've had two issues coming with the human relations, employee fairness issues, critical care. We had two appropriateness of care issues that these cases get reviewed through the Med Staff Quality Improvement Committee. We had two issues through the emergency room. These are translation services, and what is happening there is we actually have an issue with our Wi-Fi and our issues that are happening, and there's a part missing to provide our internet services. So that's the problem that's happening with our Wi-Fi and our translation services down the EB. They finally cracked it down. So that is actually an important thing for us to keep following, because we do have to have translation services, especially in the summer.
Contracted subscription or something?
It's a contracted subscription, and the problem, we can't get it working effectively right now until this part comes in from FirstNet. And then we have two issues with inappropriate access, down people going back into the emergency room. And then the next ones are some human relations issues with facilities and food services that were referred over to HR. And then, let's see, laboratory employee fairness, has been resolved. We have a couple of issues that are pending with medical appropriateness of care. A couple of human relations issues on it. I have one case in OB that is coming for a case review. The operating room, we had a couple of cases here of human relations, communication issues. And then we have a case reviewed for that resulted in a process change by the Med Staff office. And then we had two cases of care that was provided by providers that were not at the time credentialed to provide care. That came up through the operating room. And then we have three issues that came up with patient access services that were referred to the HR. And then we've had a couple HIPAA issues that have been investigated and closed over by Rachel Stark through who's our HIPAA privacy officer that have been reported. So this is our totals for Q1 right now.
I would like to ask you some questions about the actual provider issues. And I think we should go into executive session to do that.
Can we do that without noticing it?
Thanks.
I don't think we can go into executive session without noticing in our, when we.
The board meeting and talk about it in more board meeting.
Okay.
Just need to make sure we tell Anita this. Well, it's gonna be personnel matter, so it should be covered.
I'll just mention it to her. Anyway. Any,
And then my recommendation is that you talk with Deb too, to make sure that you have appropriate staff that you want.
Any general questions about the report?
I have more.
Oh, I'm
I
sorry.
have more.
A question.
Yes,
These numbers seem small to me, Gail. Are they,
That's just Q1.
I know, but are these bad numbers in your experience, good numbers? And what are the most egregious things, I guess, on the 30,000 foot level? Now that it's been a number.
I think, okay, if you can go back down, Sharon. My two, I think probably one of, I think I worry about the operating room is probably my biggest concerns, on it. I think we have, we have some cases that are being reviewed appropriate through MSQIC, which is appropriate, and those that are being closed out. I would say this is about normal, where we fall. And then I think the employee issues are probably about normal. I'm looking at Chad for something about normal.
Yeah, and this actually doesn't include things that come to us directly. So these would be things that are filed to the occurrence reporting system, which I would say is probably 60% of the things that come to us. So there's more things that would be on here had they been reported through the occurrence reporting system, but they come to us directly, which I think is also a win that the people are coming to us directly to have those conversations, that they feel like they can come and have those concerns vetted thoughtfully through the same process that they would get if they put an occurrence report. So, but it is less easy to report. So obviously these numbers are low compared to actual.
Okay, so we don't combine those that are reported directly. I mean, the issues are likely to be the same or some similar to what we're reporting here. Is that correct?
I track things that come through compliance and tracking it. Because if it has a compliance issue, then I will track it. On it, Chad may track things that have a HR component in it. So
So do you get crossovers?
Yeah, sometimes things will go through Gail's world and she'll be like, this is more of you, or sometimes she'll take something on that's like, this is really more compliance oriented. So we just have a consistent back and forth to determine that.
So you punt stuff over to compliance as well?
It all funnels through, but if something is, yeah, there are times that people come to us and I'll look at them and be like, that's really a compliance issue. Let's start up there. And then, usually we'll either send the individual or myself, the individual, or whoever it is, will go up, talk to Gail at our scheduled time, and then determine whether or not how that needs to be worked through, whether that's an HR process or a compliance process or a combination of that.
or we do together, we do combined investigations. Yes.
Not beating a dead horse. The 30,000 views, Dr. Roster always tells me. And in general, Gail and Chad, there's no real major concern. Is that correct? Are you saying that there is?
I'm on a trend. Last year I didn't trend as much in departments. What Chad and I are wanting to do this year is we're wanting to be more proactive in looking at departments and then looking at this with our engagement data and really looking at being more proactive and trending and getting a pulse survey out. So with Q1 and Q2, if we're looking at trends and being a lot more proactive and saying, oh, is there an issue? Is there concerns? And really addressing things and not waiting until we do our next engagement survey. So it's a different approach this year. So using data to address things rapidly.
Other questions?
I have more. So patient grievances so far in 2025. We had 2 related to quality of care at the oncology clinic, 1 in the med surg, 1 in mental health, 1 in the emergency room that went to peer review. We had a patient gender issue in PAS. Had a HIPAA confidentiality, which resulted in a change in unit practice in MHU. We had a pain management in the surgical unit, which resulted in some staff education and training. And then we had a inappropriate discharge from mid-surg, which went to peer review. So, and that is about, that's about average.
Be a trend with this too much.
So with the HIPAA confidentiality, there's some cases where you have to notify state, federal,
Mm-hmm.
yeah, and you would let us know in those cases. Yeah. Thank you.
Was the inappropriate discharge from hospital or just from unit to unit?
This is, I usually put down what the person says. It may not be the final what it turned out to be. So this is usually like the person that said it was a HIPAA confidentiality issue. It actually was not a HIPAA confidentiality. Once I researched it and looked at everything, and the same thing. The person says that they were inappropriately discharged. So this is what they're telling me. So.
Gotcha.
Go by what they say until proven different. And then ongoing tasks, doing our annual compliance risk assessment, getting a audit calendar a little bit more robust with Rachel and Tammy, and then updating and making our compliance work plan a little more not static, which we've had in the past. So those are my 3 tasks that I'm working on, quarter 1 and quarter 2. Now I'm done.
Okay. Questions for Gail or team?
Yeah. I like the new reporting one.
Thank you.
I was gonna just say that I didn't go to the last quality meeting and I really liked the way you set this out. I thought it was very easy for us to follow the packet along. So thank you very much for doing this. I know it was nice.
Come up with your education for life. Maybe hospice.
I think that would be.
Start changing their reporting.
I have a question.
Yes.
What does Petersburg do? They are not as big as us. Do they have a Gale?
I don't know. I like Petersburg though. There's good fishing down there.
It is. I'm just curious. I mean, that's a lot of work.
Well, Airlifts, was a company under 100 and we had to do all of this.
Yeah.
So.
Yeah, trying to get down to 600.
And that, when you guys are writing all these policies and changes and everything, are you buying them and then revamping them to us? Or are we just actually rewriting them? You have to answer me those.
Oh, why isn't it?
There's programs that help you with that.
Yes, there is.
I know. Please.
Well, I gave you that link to the UW, right? So you can grab they'll share policies.
Yes.
Okay, any other comments or questions? Thank you, Gail and team.
Thank you, Robert. Thank you, Tammy. Thank you.
Thank you.
Thank you.
Adjourn the meeting. Thank you, everybody.
Okay.
So how many days